Okay, so welcome to the second in the foundation job series. So today we're going through urology. We're really blessed to have Dr. Liley with us. Please tell me I said that right, because I didn't ask before. Who's an incoming urology-themed core surgical trainee. So a little bit more about him. Here's the next slide for me. I'll just let some more people in. So I was graduate of University of Manchester in 2023, so a couple of years ago now. Did the foundation program kind of in the same area, and then has worked as a urology junior clinical fellow for the past year. Sat the MRCS in September previous just gone, and well done, congrats, has got his ideal core surgical training place. But just to kind of give everyone a bit of hope when it comes to kind of applying for higher training, the reason why he took that urology junior clinical fellowship is that, do you want to do the big reveal?
Yeah, I think I'm probably better off.
Probably better from you
telling my
explaining
life
it.
story. Yeah, so I was a grad from the Uni of Manchester. I did foundation up in the northwest at Lancashire Teaching Hospital, so Preston, Chorley area. I did. I'm just kind of finishing 12 months as a fellow. This bit on the MRCS is actually wrong. This is fraudulent. I'm sitting part A in September 26th, so that's just a typo. I do apologize for that. And yeah, so I start my CT1 in August, continuing at Preston in a urology-themed job, and then I'll continue on up to Bolton and Wigan for a year. And I think I put that on there just to highlight kind of I'm probably coming from similar sorts of backgrounds to everyone else. I've not done anything special or fancy. I did apply for core surgical training last year, and I got an offer which was suboptimal, which was multifactorial, but essentially I rejected that offer, and I've done this year as a fellow, and I just thought I'd include that because actually I think for more and more people the route through and into training is not straightforward, and you don't need to worry about kind of taking deviations from the path. You will eventually get to where you want to get to, providing you kind of put the work in.
So just a little bit about Medics&Me and how we can support you. So we're a national charity supporting both aspiring medics, medical students, and more so postgraduate kind of doctors. So we have lots of teaching opportunities for anyone starting F1, anyone who wants to get involved. We really, really love it. You can come, you can teach aspiring medics from state schools. You can come in and help build community within medical schools and really just kind of help those who are coming after you. As part of that, we also do a lot of QI and research, which QI is going to be an essential part of your F1 and F2 years. You have to run a QI project. So we can definitely help support you with kind of learning how to do that, and having a community around you, at least for me, has been really, really beneficial to understanding a lot of that kind of hidden curriculum that comes with being a medical student and a doctor. Feel free to check out our careers blog for kind of more information on the careers available to you in medicine, or come and be a mentor or come help some aspiring medics out in schools. You've come to this event, which means you've probably already seen some form of our social media, but check us out on social media. And this whole series will be up on YouTube for you to come back to if your F1 job isn't first urology, maybe it's your third rotation. By the time you get there, you'll have had a lot of other stuff going on in your head. I'm sure you won't remember every detail of this, so it'll be there for you to go back and look at. So take it away. Thank you very much.
Absolutely, thank you. So I think this is really going to be quite a whistle-stop tour. If anyone has any questions, please just stop me. But we will try and keep a little bit of time towards the end for questions, but there is quite a bit to get through. So I think I'm just going to start with some general slides on kind of what it means to be an F1 within a surgical rotation, and then we'll be a bit more specific around urology and go through some common pathology, some must not misdiagnosis, and just a couple of bits and bats related to that. We'll have a look at some operations and procedures within that, and then we'll talk about portfolio and whatnot afterwards. Um, so I've just put this slide up just to kind of get your minds rolling about kind of what you want from your foundation job, but also to try and balance that with what an NHS trust probably wants from its foundation doctors. There are differences, but ultimately, I think we do all want the same thing, which is safe care for patients. But your priority is likely to be your training, and you have to balance that with service provision, and it is difficult. But hopefully, by the end of this, you might feel a little bit more confident about taking opportunities as they come and developing your own training. So, what's the difference between an F1 and an SHO? I think I just wanted to highlight this because clinically in the workplace, sometimes it can seem like there's a lot of difference, and all that will come down to is experience. But actually, I think a good F1 is worth their weight in gold, and they can be just as good as an SHO. On paper, from a legal perspective, an F1 only has provisional registration compared to an SHO, but actually, in terms of the day-to-day and your clinical capabilities, they're completely and totally determined by yourself, and how outgoing you are to try and get yourself trained. So for some of the things we'll look at, we'll just look at some of the skills that are transferable for any F1 on a surgical job. We'll look at some key things which are kind of inherent throughout, such as the list, how to document ward jobs, prescribing, some simple procedures, particularly within urology, and just some little bits about safety. So I was trying to think about what the role of a foundation doctor was, to therefore try and think about what the expectations are likely to be. But I actually think that the GMC's UK Foundation curriculum program really highlights this well, actually. And if you look at the higher learning points, which is what you'll be mapping your curriculum and portfolio to, you clinically assess people in a variety of settings, you prioritize and recognize where appropriate to initiate urgent care, you holistically plan, you communicate care. And we could go on, but essentially you do all of these things, and it's a really multifactorial, important role. But I think there's a lot going on. I think that's a good place to go to, and it's something you can just find easily on Google. It might be something worth looking at just before you start foundation to hit the ground running. And that was just highlighting the same points again. I think both can be achieved, but it's just about having an awareness, particularly before you start your job, that there can be clashes within priorities of interest from trainees and from the workplace. I thought this was interesting just to share because I think as a foundation year doctor, you often don't understand the role of your job, but particularly the role of other people's jobs within your department. And actually, if you do, I think it gives you a better understanding of your role and the reason that your job works the way it does. So, for example, for a middle grade in most surgical specialties, the morning might start with a handover. Quite early on, they'll go to a theatre meeting. After that, they might prioritise seeing unwell patients or seeing the patients that are prepared for theatre. And then in the afternoon, they're likely to be completing ward rounds with you, seeing your referrals on assessment units or in A&E, managing unwell patients or taking patients to theatre. So the time frame of the days is very similar to your day, but just the content is slightly different. But essentially, nobody can do this job, and the middle grades and seniors can't do their jobs without the very important role of an F1. And for most people, people think that this is just the list and prepping patients, doing ward rounds, doing jobs, clerking. But although this is kind of the key components of what you do, if these are done in a timely manner and are done with some competency, then it really frees up your time to go to theatre or clinic, seek extracurricular opportunities, or do some admin, some research, some projects. And the job is really what you make of it. And you can quite easily go through a job having done none of the things on the right, but you can quite easily do all of the things depending on how keen you are and if you've got a supportive workplace. So I think it goes without saying, and I think in traditional specialties like surgery, they're a bit more important, but being on time, accountable, and responsible. They're very basic, but the things that make a massive difference and the things that the bosses notice. Just escalate early and appropriately, and be safe. And I think that's the main thing that anyone will ask. Expectations can be low, but as long as you're safe, that's the main thing. Kind of surgery specific things. So I think a key thing that I noticed when I was a foundation doctor is that you really help glue the team together and you help manage the problems kind of around surgery, so the medical problems in the perioperative period. One thing that's important in surgery is the list. So every specialty has a list. I'm sure there's many fifth years on here who have done ward rounds, and the list is kind of the Bible, if you will. If that list is not there, then your bosses don't know who needs to be seen, what the problems are, and so detail on there is important. So I know it sounds very basic, but making that something that you do well is something that will go really far. Scan the bloods are things that are really important within surgery, and if they're not done in a timely manner, they will cause delay. We often see it that the bloods have not been taken as requested, and then in the morning plan is to get the bloods on the scan, and then by mid-afternoon it's still not done, or it gets done late afternoon, and then there is no time to do an operation for that patient, for example. So just having an awareness of the things going on around you, and kind of being proactive and thinking about things like scans and bloods and how important they are to your patients is something really crucial. So, for example, when I used to come in as an F1, once I prep the list, the first thing I would do is see who needs urgent bloods and scans and make sure they'd happened and been done on a timely manner. I think clerking and initiating simple plans is something that's really important. It's something that people do in medicine quite a lot, but I see more and more that it's happening less, that the juniors in surgical specialties doing clerking, but it's really important. It's the first point of contact. It helps a plan get put in place, and it's also really important for your learning. I think as part of surgery, you should be expected to do simple procedures, but this is also something that you should be proactive in seeking opportunities to gain expertise in. And I say be the safety measure. Often if there's a whistle stop tour of a ward round and your bosses are thinking more about what operation they're going to be doing, or the unwell patient on another ward, then they might forget about the antibiotics, the VTE prophylaxis, or the scan results that's just been reported. So just think about all these things on the ward round and be thinking how you can raise these as issues, ensure they've been acted upon, and ensure that we've got clear things in place like escalation status for a frail patient who might be at risk of arresting. So nothing that's rocket science, to be honest. I think to stand out as a good F1, just work hard, show interest, and seek opportunities. I put remember this is your training because when you start your job, and it can be quite demanding, and sometimes you forget that actually this is your training and you need to try and put effort in, and you get out of it what you put in. If you don't show interest and just try and cruise through the job, most people probably will cruise through the job, but the foundation program is quite well termed. I think it does form the foundation of your knowledge, and the things that I've learned in my rotations, for example, in renal, cardiology, obstetrics and gynae, I kind of still use today. And for the specialties that I've not done, I rely on my colleagues who might have experience in those areas. So really engage with it and really engage with your jobs is my main thing to highlight. But we'll move on to clerking, assessment, starting a plan. I think this is something that you've been doing all the time throughout medical school, and it's just something that becomes a little bit more formalized. So clerking is seeing the patients as they come through the front door. And my tips for that would be to do the basics well, really. So even now, well after a patient has come in, they might have been on the ward for days, I will still go back to the initial clerking because it gives a really good summary of what they came to hospital with, what their history is, and even little important things. For example, when you're deciding about whether or not a patient would benefit from a procedure or an operation, So social history is really important. If you find out that they're bedbound, really frail with poor performance status and highly comorbid, then that might be something that helps inform your decision making. So clerking is really important, and it's important that you do a thorough job. Um, when you examine thoroughly, and always take a chaperone with you. I think these are just simple things which are really overlooked. I've done a chaperone audit, and very few people ask for chaperones, but they're a massive cause of problems and litigation and complaints. Start basic. I think lots of people are put off by clerking because they think they have to put a definitive plan in place, but that's not the role of clerking. You're the first doctor that a patient might see when they walk through the door. So put a simple impression in place, put a simple plan in place. Um, and simple tests, bedside test, clinical examination, your bloods, your urine dipstick test, they're often enough to give you the answer. And if you don't know the answer, then discuss it with the senior. Um, I think it's very easy to get caught up in pattern recognition, especially when you're working in something like general surgery or urology as well. We get lots of the same complaint, abdominal pain or query renal colics. And I would just say use your medical knowledge. Don't use pattern recognition because that's how things get missed. Um, for example, just cast a really wide net so you don't miss any dangerous diagnosis. And just as I was speaking about before, something that will make your bosses happy and also improve your patient's care is you being really proactive and thinking early antibiotics for your septic patient or an early scan for a patient that might need to go to theatre is really important. But things don't just happen. So just because you put a request in on the system doesn't mean it's going to happen. So please chase these things and make sure that they happen. But I think clerking is also something that's a little bit difficult to access depending on where you work and the types of department. Um, so you can often find yourself as an F1 getting stuck on the ward, doing the ward jobs, and then having difficulty to get onto the assessment unit or to A&E. But I think really just be proactive. If you ask for somebody to come and support you, or if you ask for somebody to supervise you whilst you do an assessment, then that gives you good opportunities to build confidence under supervision, and you can get a CBD or a DOPS or a KEX or whatever assessment you need for your portfolio out of it. So I'm just going to go through some of the pathology that you might see on the on-call, which might be a bit more interesting. We're going to go quite quickly through it because there's a lot to cover, and all the information is on the slide, so we'll send those out anyway, so don't feel like you have to make notes or anything. If there's any questions, then please just stop me. But a lot of this is just some information that I wish I'd known when I started. So renal colic is something that's very common, and it comprises a massive amount of the work that we see on the on-call within urology, but also takes up a lot of time in theatres and in clinics. So stone formation risk factors, so people who are dehydrated, high protein, high salt diets, diets high in oxalate or purines. There's medical problems which can contribute, so things such as hypercalcemia, and other conditions which might cause them to have high serum ureas, for example. Family history can sometimes be common. So calcium oxalate is the most common stone, but feel free to have a Google. There's lots of different types of stones, which you could spend a lot of time covering. So I think one of the simpler ways to split this up is by anatomy. So we can talk about stones within the kidney, we can talk about stones within the ureter, or we can talk about stones within the bladder. So stones within the kidney, if they're within kind of the meat of the kidney, if you will, they can be tend to be non-obstructing, so they're not causing an obstruction to the flow of urine. They may cause mild pain intermittently. If they're small and not causing too many problems, they often don't need anything doing. Maybe just somebody needs to keep an eye on them. If they're a little bit bigger, they might benefit from some sort of treatments. That might be shockwave therapy. It might be something like PCNL if it's a large stone, but we'll come on to that. So stones in the ureter are more of a problem, and these are things that you would be more concerned with. So these tend to present slightly differently. They come with acute unilateral colicky flank pain, tends to be radiating from the flank to an iliac fossa. I've put lots of female patients say worse than labour, and that's definitely something that's been quoted to me many times by female patients. So I think the only reason I'm highlighting that is to say take it seriously. These patients are in lots of pain, so give them good analgesia early. The reason that stones in the ureter are a problem is because they can cause obstruction to the flow of urine, and they can also cause infection. So if a stone gets wedged in the ureter, then the back pressure will cause some swelling within the ureter, hydroureter, and possibly some swelling within the renal pelvis and the kidney, hydronephrosis. And that can cause the renal function to become deranged, which untreated can cause problems. The other issue is that trapped urine behind a stone in the ureter can become stagnant and infected, and the kidney is highly vascular. So through your lymphovascular kind of circulation, you can get a very quick systemic infection and urosepsis, and patients become very, very unwell. And this is something that can't be missed and needs to be treated early. So if you have a stone in the ureter that is quite small and the anatomy is relatively normal, then it may pass. And we're talking about stones that are probably less than 5 mm in size. Stones that are bigger than that will have a higher tendency to get stuck. I've not included it on this slide, but something called the MIMIC score, MIC, is a large study that was done looking at the statistics of spontaneous passage for these sorts of stones. So you can actually calculate and give someone a percentage chance that they'll pass the stone, but it also can help inform your decision making. So stones in the bladder, sometimes these originate from the kidney and drop down into the ureter and then the bladder. Sometimes in people who've got kind of chronic either infection or they've got bladder outlet obstruction, they can form stones within the bladder from the sediment within the urine, and it can be a primary bladder stone. Most of the time, if they're small, they will pass. But sometimes they can be something that precedes recurrent UTI and sepsis and infection. And sometimes they may cause retention. And if they're causing problems, they might need an operation to sort them out. So, like I was saying, the stones in the kidney tends to be non-obstructing, can cause mild pain, don't always require treatment. I've got a CT scan on the top right of your screen, which shows a very large staghorn calculus within the kidney. This is obviously something that would need doing. You can't clearly see the ureter in this slice of the imaging, but there may be some degree of partial obstruction. As the stone is so large, we, in terms of options for surgery, I put it on the slide, we would consider either an antegrade or retrograde approach. Antegrade approaches just means following the flow of urine, so as in access from the kidney and down. Retrograde would mean that you would manage a problem against the flow of urine, so you go through the urethra into the bladder, up the ureter and into the kidney. A big stone like this would likely need something called a PCNL, which is a percutaneous nephrolithotomy, a puncture in the patient's back or their side into the kidney, and then introduction of an instrument that can kind of break that stone down and suck it out. With this size of stone, they would likely need one or two, maybe more operations. I think if you was to try to do this from a retrograde approach, I'm not a stone expert, but this would likely need many, many sittings and would probably be a very difficult operation. Very rarely, I have seen that people have had a nephrectomy, particularly if they have a massive, massive stone burden, and there's some evidence to suggest that the kidney has become non-functional, in which case, if it's not contributing to your renal function, causing problems like pain and recurrent infection and sepsis, then actually it might be better to remove that kidney. But this is something that needs a lot of further investigation with different types of scans and needs a senior and MDT-led approach. The CT scan below just shows some smaller stones. So these are the types of stones that I'm saying are much smaller. They're non-obstructing, they're not within the ureter or obstructing the flow. Depending on the size of these stones, you would likely pass them. But for example, you might want to offer someone either some shockwave treatment, or you might want to offer them a retrograde approach should these stones keep growing and not pass, for example. So this is just to highlight what a PCNL will look like. As the urology F1, you might see these patients on the ward round post-operatively, so I think it's good just to get an understanding. So essentially, you can see the image to the right, there's lots and lots of different screens, and there's the X-ray machine in number 6 there, the patient's previous scans, or the fluoroscopy screen for the X-rays there, and then they'll have the screens for the nephroscope. So a puncture is made into the kidney, under X-ray guidance, and then we introduce instruments which allow us to visualize the inside of the kidney to remove the stones. It's a really good, interesting operation to watch, and I highly recommend you go to a list and see one of these if you get the opportunity to. Retrograde approaches, so this is, as I was talking about, for stones where you want to access it via the urethra and then the bladder up into the ureter to find your stone, or up into the kidney as well. So if we're going into the ureter, this is ureteroscopy. We're going into ureter and kidney, this would be ureteroscopy. You can see the patient here has got their legs up in the modified lithotomy position, or Lloyd Davis. They've got the X-ray machine above them. Again, all the screens giving us views from our scopes, but also the X-ray monitors. This on the left, this smaller instrument of the two, this is a cystoscope. So this is a rigid cystoscope. So this is something that we would gain access to the bladder with, and then we can use guide wires under X-ray guidance to help us get into the kidney. And after that, we would use the instrument to the right. This is a semi-rigid ureteroscope. So this allows us to get into the ureter. We don't use this in the kidney, but all the way up to the renal pelvis. We can go with a semi-rigid scope. And there is some guide wires and some raspers there for getting hold of pieces of small stone fragment. So again, just some images. So this is the cystoscope down here on the left. And they've done what's called a retrograde study. They've put some contrast at the ureter. You can see where the red arrow is. There is an area where the contrast has not become highlighted. So I don't know if this is a stone in this case. These images are just off Google, but that could be a stricture, a narrowing, or it could be a stone or something, a kink within the tube. But what we can see is that there is something there that's potentially blocking the flow of urine. Further up, so that's the lower ureter, but further up you can see the retrograde studies in the kidney, which then allow us to map out the different calyces. And then the image to the right is an image of a stone, not sure where, but it's, you can see that they're using a laser to kind of zap it. Fine. So for getting into the kidney, we've talked about how we would use a semi-rigid scope, semi-rigid URS to get into the ureter. An access stone, but for stones within the kidney, a flexible URS, ureteroscopy, is something that you would want. And you can see here, they've mapped the kidney with contrast, and now they can inspect the different calyces to find the stones. And you can see that this is a safety wire that they put in the kidney, so they can leave a stent if there's any problems. So talking about stents, normally after somebody's had stone treatment, or before somebody's had stone treatment, if they're septic, but we'll come on to that, a stent is placed. So if someone's had an operation, the stent will be placed for some time afterwards. It might come out after a couple of days, it might come out after a week or two, or it might get left in until they have another operation. So this keeps the ureter patent, allows urine to flow around it. This allows decompression of the system and allows any infected urine to also drain. And later, when we want to remove them, we go into the bladder with a flexible scope, and we use this instrument on the right to grab hold of it and pull it out, essentially. Now, sometimes we leave them on strings coming out of the water pipe if they're only staying for a few days, in which case you don't need a flexible scope, you don't need this procedure, and the stent is easily removed by the patient on their own with some information to help them. Now coming down towards the bladder, so you can see here on the X-ray pelvis that there's multiple stones within the bladder, which will require some treatment. So on the side there is what we call a stone punch, which can be used to break those down. So for small stones, which are in the distal ureter, there's some evidence to suggest that tamsulosin, which is an alpha blocker, can be helpful to allow them to pass. Side effects include erectile dysfunction and low blood pressure, so you just need to counsel your patients on that before you start them. Diclofenac suppositories are on the side there. These, I would say, is probably the best pain relief for renal or ureteric colic. So if a patient's coming to you with CT-confirmed ureteric colic and they're in loss of pain, then I think diclofenac suppository, if there's no contraindications, is probably the best analgesia option we can give. It's something that we like to use a lot. So the must not miss emergencies, sorry, that are related to stones is infected obstructed system. So as I was saying, a ureteric stone can block the kidney, causing obstruction, but it can also become infected. An infected obstructed system is an emergency, which does require emergency management. So the way we'd manage that is with decompression of the urinary tract to allow the drainage of infected urine, allow decompression of the pressure on the kidney, and then at a later date we would come back. So first of all, we would likely attempt to stent if it's safe and the right thing to do, and then we'd come back and do a laser procedure, potentially spray the stone down, or another procedure if that's not appropriate. And I've just put in red there, pyelonephritis in a male is infected obstructed system until proven otherwise. So pyelonephritis, which I do have a slide on, normally unilateral, can be bilateral, but infection, inflammation of the renal parenchyma is very common in females, but is not common at all in males. In fact, UTI is not necessarily that common in males without a pathological process behind it. So if you see a man who you think has got pain in his renal angle, low urinary tract symptoms, and symptoms of infection, potentially signs of infection on the blood test, then you need to get this patient a scan of some sort to rule out an infected obstructed stone. So if you ever see a man with these issues, then I would always be looking to get a scan where possible. The other option, apart from a stent to decompress a kidney, which you will see quite frequently on the urology wards, is a nephrostomy. So you can see how the JJ stent, called that because of the two coils here, is sat within the kidney and then comes down to the bladder. Well, similar sort of thing with a nephrostomy, but it's just going through the skin, it's percutaneous. So that's a nephrostomy. And as an F1, you might get asked as a simple procedure to remove a nephrostomy. I'd get someone to show you the first time, but they're really simple. You just unlock the mechanism here, which allows the tension on the string to release, which allows this coil to unfurl, and then you can just pull it out. And you don't need to, it's only a tiny, tiny hole, so you don't need to stitch it or anything. It will heal secondary intention. So when you're thinking about your renal colic patients that come, please just think about the other dangerous things within the abdomen that you might miss. So classic but not common is your AAA and potentially your ruptured AAA. So just be really aware. I think I ensure that I document on every patient that I've seen that they've not got a pulsatile mass. Just you need to cover yourself, but also it's a good reminder to yourself to ensure that you're checking for a pulsatile mass when you're examining their abdomen or thinking about the risk factors for AAA. So this slide just kind of summarizes. So non-obstructing renal stones, if they're small, they might pass. If they're big, they might need some outpatient elective input. Do they need a PCNL? Do they need a multi-stage URS? Obstructing ureteric stone is an emergency. If there's infection, there's an emergency. If they're clinically septic, it's an emergency. And if they only have a single kidney, or a patient where their renal function is really important, such as a chemotherapy patient or a patient on dialysis with end-stage renal failure, then this is something that you really need to diagnose and manage early. If you've got small non-obstructing ureteric stones, so I'm talking about the small stones that are not causing any problems in a clinically well patient, then it will likely pass potentially with some tamsulosin if it's distal. If it's large, they might go on to need an elective procedure. But remember, even if it's non-obstructing, but they have an infection, it's a compromised urinary tract system, and then they need something urgent doing. Bladder stones, most will pass if they're small. If they're not, then they might require an operation to sort that out. And there's also underlying causes, so just consider that. Pyelonephritis, just briefly touched upon. So this is infection, inflammation of the renal parenchyma, normally caused by common urine tract bugs such as E. coli, risk factors being female, if you have any anatomical abnormalities within the kidney, or if you've got any urinary reflux. Immunocompromised patients such as diabetics are really at risk of this. They come with flank pain. They're normally unilateral. They're normally spiking high temperatures. They might have a preceding history of low urinary tract symptoms such as dysuria, urgency, frequency, and they might just come septic and unwell. So do your clinical assessment, do the basics, your urine dipstick, your bloods, If they're young and female, you might think about an ultrasound first. The reason you're doing an ultrasound is to ensure there's no hydronephrosis or no obvious obstructing stones. If they're not getting better, then you need to think outside the box. Could it be an infected obstructed system? Could it be a renal abscess? So at that point, we need a CT with contrast. CT for stones is non-contrast, but CT to look for renal abscess, you need contrast to look for that. So management, you manage them quickly with sepsis 6 approach. Try and identify the cause, as we talked about above, and then just tailor the treatment with cultures and whatnot. Just be aware of these patients and be aware of the infected obstructed system patients. These are the patients that, if they're not managed properly, will go to intensive care, even if they're young and fit. I think that just summarises what we said. Sepsis 6, get an urgent CT if CT is most appropriate. Early senior input, get prick care outreach involved if the patient's clinically unwell. Make sure they know by mouth in case they need an operation that's confirmed on the scan, and stop any blood thinners or anticoagulants in case they need to go to theatre. So they're just basics that you can transfer to any surgical specialty, but particularly with when you're worried about affected obstructed system, just think about these things. You'll see a lot of haematuria, and I've put this on just so you can have an anatomical approach to thinking about the main things which might cause it, but there's lots and lots of different causes, lots of haematuria in a bag. There's different grades of haematuria. I think that this is, you can see in the tubing is actually quite light. And I always tell my patients, if you drop a bit of Vimto in a massive tub of water, then it will turn pink like this, and actually it doesn't represent that much bleeding. If it's a deep red wine, like a Merlot kind of colour, then you need to be more worried. If there's clots, you need to be more worried. So take a thorough history. It will normally tell you the diagnosis. If they come with pain, think about stones and think about the things. If it's painless and they're older, then think about the possibility of cancer. So for you, when you're initially assessing them, you think about the fact you've got bleeding patients, take an A to E approach. Check their blood count. Do they need transfusion? Now, from a urological perspective, we manage these with 3-way catheters if they're bleeding significantly. And that's mainly because we're managing the complications of bleeding. So if they're bleeding, they'll form blood clots. The clots will block the water pipe or a catheter, and they will develop clot retention. So that's why we use a large bore catheter. We wash the bladder out and we use some irrigation to prevent the clots from reforming. Low threshold for antibiotics, they tend to have an infection, and if they don't by the time you've done all your interventions, they probably will. Very occasionally, these patients go to theatre if they've got persistent bleeding. So a 2-week wait clinic is what you need to rule out cancer if you're worried. So you need to visualize the bladder with a flexible cystoscope. The gold standard for upper tract imaging to make sure there's no cancer coming from the kidneys or the ureters is a CT urogram. Just be careful of patients with poor renal function. And if it's someone who's really old and frail, that probably wouldn't be fit for a nephrectomy anyway. If that decision needs to be guided by your boss, but they could have potentially an ultrasound or a CT-KUB. Just make sure there's no big obvious masses there. Some scrotal pathologies you might see. Epididymo-orchitis is really, really common. So infection, inflammation of the testis and the epididymis. They come with tender unilateral swollen testes, erythema, features of infection. They might have a preceding history of lower urinary tract symptoms. Do the basics, but ultrasound is normally diagnostic, but you can make this diagnosis clinically. You manage it with fluoroquinolone antibiotics. Very occasionally, they need surgical drainage. One of the main reasons that you would get an ultrasound scan is because these patients are in lots of pain. You can't examine them properly. You need to make sure that there is no malignancy. Some common other things: hydrocele, varicocele, epididymal cysts. Common. They don't always come to hospital acutely, but we normally manage them in an outpatient, and they can be diagnosed with an ultrasound. Inguinal-scrotal hernias you will see commonly. They're normally managed by the general surgical team, but there's not many times that they will come to hospital acutely. And when I talk about acute management is where I'm talking about the urological acute management. Obviously, if there's an incarcerated hernia or something, the general surgeons will need to do something. The main thing that we worry about is obviously testicular torsion. So initially you get reduced venous outflow and then reduced arterial flow. So salvageability will start to fall after 6 hours. So It's important that patients come to hospital as quick as they can. Will tend to be a young boy with short duration, severe unilateral testicular pain that doesn't tend to get better. Have a look at the twist score, which is something that can help you make a diagnosis. But these are the patients that you should be calling your boss and asking them to come and see, as in the registrar. And just think about the fact that torsion can sometimes present a little bit differently. So lower abdominal pain in a young child, for example. And just be aware of torsion detorsion. Sometimes patients will have torsion symptoms that just get better, and then they may recur again. So sometimes the testicle can twist and untwist, and they might need something doing as an outpatient to fix that in place. So have a look through these slides in your own time, because we've still got quite a bit to go through, and I'm running slightly over. But they're the main examination things. But the main thing to take away is, if you suspect torsion, they need to go to theatre immediately, unless a senior doctor tells you that that's not the case. So make them nil by mouth, give them some pain relief, maybe inform an anaesthetist, definitely inform your boss. And ultrasound is only ever used if you have immediate access to a very senior radiologist who can do that ultrasound there and then for you. Otherwise, you're just delaying the patient's care and they should go to theatre. Retention, very, very common, and the causes for it are multifactorial, but and there are many, but I think the easiest way in my mind when I first started is to split it into acute, chronic, and high pressure. So acute retention is your classic patient who comes unable to pass urine over the last day or so. They might have a significant palpable bladder, like this gentleman here, and you essentially need to get a catheter in them. There's lots of different causes. Might be something simple, constipation, post-op, painkillers. Might be UTI, that's also something that's really common. Or it might be actually a first presentation of someone who's got benign prostatic hyperplasia. We normally put a catheter for these patients, and if the output's not too high and there's no other concerning signs, they can go to a TWOC clinic where we try and take the catheter out, see if they're passing urine again. And if not, we put the catheter back and then we see them in the outpatients and come up with a plan for them. They may need some sort of medical or surgical input. Chronic retention tends to be painless. Somebody just does a random bladder scan and they have very large residuals. They have over a litre in the bladder, and low pressure systems, not a problem. A high pressure system, which we'll come on to in a minute, is potentially an issue. So when you've got high pressures within the bladder from chronic retention, it can put back pressure onto the kidneys, the kidney function can fall, and sometimes people do present in renal failure. I've seen patients with an EGFR of 1 who've needed acute dialysis with these sorts of problems, so it can be very concerning. So if you see a patient with signs of retention with a large post-void residual and they potentially got deranged use and ease, or when you put the catheter, they drain more than a litre, then don't send that patient home and don't take the catheter out. Make sure your boss sees that patient. These sorts of patients, if you take the catheter out, they will go back into renal failure. So they need to keep the catheter until there's a definitive cause found. I would urge you to do a digital rectal examination for all these patients that come with this sort of issue, because a small proportion of them, this may be a first presentation with prostatic cancer. So make sure you do a DRE. PSA wouldn't be useful acutely, but is important generally. You can have a read over this slide in your own time, but it's just more about HPCR, which we've touched upon. Something as an F1 and SHO we get asked all the time is to help with catheter troubleshooting. So if someone says to you that a catheter is bypassing, it likely means that the catheter is blocked. Urine will follow the path of least resistance, so urine will drain around the catheter if there's any sort of blockage. Sometimes bypassing catheter can be overcome by changing the position and resiting the catheter, but often these are block catheters. So you can either change the catheter, put a bigger one, or you can do a bladder washout, particularly if they're currently blocking. Sometimes an open-ended catheter under senior guidance might be better for that patient. Catheters falling out all the time, think bladder stones. And if for people who are having difficulty putting the catheter, 9 times out of 10 technique will help. So pulling the penis straight up to the sky to eliminate that bend in the natural urethra, and using lots of instiller gel will help If you're getting stuck at prostate, then a Team and SIP catheter can help as well. There's lots of other different reasons why you might get difficult catheter, but I would just suggest that you ask if you can go with the middle grade or the SHO and just try and watch what they do and see, because there's lots of different ways for managing difficult catheters, and this can even include flexible cystoscopy and dilation of the urethra. SPCs, they're quite daunting at first, and I don't really know why, but you get used to them quite quick. Exactly the same as a catheter, if anything. The tract is very, very small, so not much to really worry about. The main thing is if it's a fairly new tract, they can heal over very quickly. So if someone's SPCs come out, you want to get one back in as soon as possible before that little tract heals up, and then they need another elective operation to put one back for them. Normally helps if the bladder has a bit of fluid in, so sometimes you can put some fluid in before you change the catheter, because it will bring the bladder wall closer to the abdomen. Difficult catheter removals. Before you do anything, just ask your SHO or your registrar, because once you've mutilated a catheter, it can be difficult to undo that, but often it's a calcified tip, or it might be that someone's put salty water, so saline in the balloon, which then can crystallize out and cause the balloon not to deflate. So there's lots of different ways, but one of the things that we can do, which is definitive, is cutting the balloon part, passing a guide wire down the channel to try and clear the obstruction, or pop a balloon. Never take a catheter out in a patient who's just had major surgery, such as a urethral reconstruction, a prostatectomy, or a cystectomy, because you don't know what kind of repair of any plumbing has been done, and you don't want to disrupt that anastomosis with your catheterization attempts. Paraphimosis is very common, so the foreskin gets retracted, forms a constricting ring, reducing the venous and lymphatic flow, and then you can't get it back over. Can cause ischemia of the gland, so needs to be managed immediately. Most of the time, manual reduction, as you can see down below, is the mainstay. You just need time, and you need patience and good analgesia for the patient. Things like lidocaine gels or topical kind of dextrose can help reduce that swelling and make your life easier. A penile block, which one of your seniors might be able to show you, is a local anesthetic, a penile nerve block, which can, from an analgesia perspective, make it much easier. Very rarely they need a dorsal slit, which is a cut to allow us to get that back over, and the circumcision might be confirmed. I've never seen it to be done, to be honest, and I find that they can normally, with patients, good analgesia, be solved with proper manual reduction. Priapism, quite uncommon, I think, but when it does happen, it's serious, so it's painful and wanted erection. They're either ischemic, so low flow, or they can be high flow. High flow is normally trauma related, where you've got arteriovenous fistula in the pelvis. Low flow, there's lots of different reasons. Always think about kind of hematological problems, which might cause them more likely to clot, so malignancy or sickle cell. Get them good pain relief. This will be painful. And there's lots of different things that we do, but you won't be doing any of this without senior guidance. So just have a read through for your own interest. If they present late, it can cause lasting damage, and they might need some specialist input. We actually take a blood gas from the penis itself, and this can help tell you whether it's a low flow or high flow problem, and you can have a look at this in your own time, but it's just a blood gas essentially, which will tell you if it's ischemic or not. Penile fractures, not that common, but serious when they happen. So you can see this kind of pinkish layer, the albuginea. This is what ruptures. And you get this classic aubergine sign. What the worry would be is if you've got a concomitant urethral injury. So if this patient has, he suspects penile fracture, but they've got urinary retention, then this is really bad, and they need probably very urgent surgical repair. So this is someone that the boss needs to know about very soon. Penile MRI can help, but it's very clinical, the diagnosis, and it's more for surgical planning than anything else. Some surgical options are there on the slides. Boni's gangrene. This is kind of a severe synergistic infection. It's a necrotizing fasciitis of your external genitalium and perineum. Tends to be in someone, an old man who's immunocompromised, might be obese, an alcoholic, diabetic, these sorts of issues, smoking. Um, Initially, you might see some crepitus, you might see some erythema, and later you might see necrosis. Gas kind of within the skin on an X-ray is diagnostic. Needs very quick management before it spreads and leads to sepsis and death. It's a broad spectrum antibiotic and surgical excision. That's enough about that. You can have a read through in your own time from the slides, but I just thought I'd post. This is my, I think, the second or third month on the job when I started in F1 in urology. So just to give you a bit of an idea what it might be like. So you can see that on that weekend there, I've got some on calls covering general surgery, but nicely you have the day off and a day or two afterwards there for rest time, and you can be very clever with your annual leave and get a full week out of using 3 days. We had teaching on a Thursday afternoon, which was protected for us, which was good. So I think we had maybe like a 1 in 4 on-call rota, but we had some twilights and nights, which would interchange with these as well. But everyone's rota will be slightly differently, will work slightly differently. So just compare it with each other's to make sure one of you is not doing more work than the other. And you can use the BMA rota checker to make sure it's compliant, which I think is very good. Some tips for ward round. If you're not sure or you're not sure what's been said, you want to clarify the plan, just ask. It's better than asking, trying to find out after the consultants left the wards. Use a bunny hop technique, so have 2 of you, do 1 patient each as you go, and whilst the other one's waiting, do the jobs from the last patient. So fluids prescribing, scan chasing, putting a referral in, you can do quite quickly as you go, which will free you up in the afternoon. On every ward round note, I would tell you to put the antibiotics, the VT, and the escalation status. It just helps. It makes it really clear if a patient becomes unwell and we're quickly trying to find out what's going on. Some procedures I talked about before, the stents, sometimes they're on a string if they're going to be removed over the next few days. So this is something that you might do as an F1, very simple. But any of the procedures that we've been discussing, you might be able to get involved in. So just be keen. Operations, not really going to talk much about. I've just put this on there to show that urology is massively varied, but also there is way too much to talk about for this one single talk. So these are the types of patients that you might see on the post-op wards. So TURBTs are really common. TURP is really common. Scrotal exploration, query torsions. There's lots of common things and there are some less common things. So just get stuck in. If you're not sure what's been done, then just ask and somebody will explain the operation to you. But there's lots of very interesting urology procedures. Just a quick bit of holding the bleed from prioritization. I'll fly through this because I know I've gone way over. So imagine you've got these 4 patients and you get bleeped about them all very quickly. You've got someone who's had a TURBT, so a transurethral resection of a bladder tumor, who's now bleeding. They're slightly tachycardic, their blood pressure is slightly low, the HB has dropped. You've got another patient who's got renal colicky sounding symptoms. A&E have currently done a CT and they've got a 5mm stone. The blood tests are there and the apyrexial. And then you've got a patient where catheter's fallen out, but they're comfortable, the bloods are okay. And then you've got post-radical prostatectomy, day 2. The drain output's now suddenly gone up to 300 mils. The HB is 119 from 123. So who would you see first? I think I'd hope that most of you would say the TURBT, the hypotensive, they're tachycardic, they're actively bleeding, and they've got evidenced HB drop, and their lactate is up. So that patient needs seeing urgently and an intervention doing. This kidney stone, as I was saying before, it's quite small. It's in the distal ureter, so it could pass. But irrelevant of that, the vital signs are stable, they're apyrexial, their blood tests are okay, so they're stable, they can wait. That might be a patient that you actually discharge without patient follow-up. The catheter can wait, absolutely. It doesn't look like they're in acute retention. The drain output is quite high, which can happen, but the the blood count's still the same. So you might be worried about either a urine leak, potentially bleeding, but the HB's not dropped too much. So I think A and D are the patients you want to see, and you can hold off B and C for now, unless there's multiple people, in which case one of you can see each one of the sickies. Very common one, you get a young girl who's got right loin to groin pain, vomiting frequency. ED thinks it's renal colic, and we said they'll book the CT, but they want to send the patient to SAU under urology. The blood test there, what do you do? Well, I think just to highlight, just be very, very careful and be very safe. So the first thing you should do is say, have you ruled out pregnancy? Because you don't want to end up with an ectopic pregnancy on SAU. Don't ever reject a referral without discussing it with a senior. It's normally somebody who's quite senior referring to you anyway from a different specialty, so just be careful about rejecting them. Do the basics right, and always ask for somebody else to come and examine or see a patient if you're worried, particularly for torsion. Don't make decisions on your own. Opportunities within urology for your portfolio, there'll be lots of procedures to do. All the different sorts of things that we've seen. You can see these patients and do CVDs and mini kexes, and there is loads and loads of QI audit and research to get involved with. So just be really proactive. Nobody will offer you these things. You need to ask for them and show interest, or you'll just cruise through and miss all these opportunities. And there's absolutely no reason why this AI-generated image can't be you. If you're really keen, you could be doing a scrotal exploration or a simple operation in theatre with your middle grader registrar. If you're keen, the jobs are all done and there's nobody unwell. So yeah, just be proactive. Just a bit about your well-being. Say try not to get stuck on Zooms like this where I just jabber on for far too long, but just look after yourself. Coffee currency is quite interesting. So people look after each other with coffee, and they'll also do you favors. So yeah, buy someone a coffee, let someone buy you a coffee, and just look after yourself. Triage things appropriately. You don't have to drop everything you're doing for every single bleep if it's a stable, simple problem. If it's 20 minutes, half an hour before the end of your shift, don't start something new, complex, unless it's something life-threatening, because I promise you, you will go home late every day if you do. Normalize not knowing. Everyone starts not knowing a thing. You feel like you should know something and you don't, but you get used to it. So just ask questions, and that's how you learn. And just in terms of kind of safety, so know who your guardian of safe working is. Use the BMA rotor checker, ask for advice, make sure your indemnity is in place, and use your CS. They're there to look after you. And if you're not sure, ask somebody else around you. So that's it. I'm sorry I ran so far over, but if you have any questions,
you just go to the next slide for me, just so that people can see that. I've put it in the chat as well, just the direct link. If people want to put questions in the chat, I will read them out, or just straight up ask. As I said, we will send slides to people who complete the feedback form. Thank you for coming along. If you have any questions, feel free to unmute and ask, or ask in the chat and we can answer. And yeah, thank you for coming. If it was helpful, I found it helpful. So thank you guys. Just lots of people saying thank you. I don't know if you can see the chat. Often when you're sharing slides, you can't, and I would rather you didn't stop sharing just in case. Okay, how would you manage your first day as an F1 starting on urology night shift?
Oh, tricky one. Not a nice position to be in. If your first day is an F1 starting on a urology night shift, I would first of all be having a chat with your rota coordinator and seeing as to why you're starting on call or on nights. I think that might be a little bit unsafe if you're not in a familiar system or in a hospital, working with people, I don't know if that's necessarily the right thing to do. I know at our hospital, people will not do night straight away. They start on days, and then the second week, people will then start their on calls. So first of all, question it. Second of all, take your time. If you are having to do that shift, then find out who the registrar and the SHO is that might be helping you, and get to know them. And they will be your biggest port of call, to be honest. So say hello, introduce yourself, and just yeah, find out what's going on. But just escalate anything that you're not sure about. That's fine.
any other questions from people. So there are still people on the call.
Yeah, if anyone has any questions that they don't want to put in the chat or ask on here, then please get in touch either via Medics&Me or Rhiannon or however.
Yeah, I'll put my email
happy,
thing. I can
yeah, I'm happy for
send
people to
any
email me with
questions.
any queries.
That's my email. So if people have any questions, feel free to just pop them across and I will get you guys in touch. Okay. Stop recording.